Dr. Cross, with respect to epilepsy surgery in the pediatric population, what are the special considerations that a clinician should keep in mind?
I think the range of surgical candidacy in children with epilepsy is much wider than you might think in an adult population. There are many children with malformations of cortical development, then they might be candidates for quite large procedures that may not otherwise have been thought of if we were thinking in an adult perspective. And one of the things we want to do is determine early which children may be candidates, early in the natural history of their condition, because of so many other problems that they may run into, not least the effect of ongoing seizures on the developing brain. We know that ongoing seizures and early onset of epilepsy is associated with a poorer neurodevelopmental outcome that can be acquired over time. We also want to improve and optimise their educational potential and their psychosocial outcome in the long term. And we have some data now to suggest that is indeed the case if we operate early. But the problem we have is it may not be obvious to these children who may be surgical candidates because of the range of ways that they can present. And even children with what appear to be localised or lateralised lesions may present in what appear to be generalised seizures or generalised EEG changes. And it's only with experience you realise that that's still the result of the focal brain lesion. We also know that there's a high rate of learning and behaviour problems, but that's not a contraindication to determining who may be surgical candidates. And finally, of course, if we operate early, there is still the degree of brain plasticity, much more than you will see in an adult population. And therefore, although epilepsy surgery we're performing, not with any minimising the chance of making them worse off, we're not in the business of making them worse off. We know that in certain circumstances they will have relocalised functions, so their chance of more problems is much, much reduced.
Dr. Cross, how should clinicians think about epilepsy surgery in the pediatric population?
I think what clinicians need to remember is epilepsy surgery in children is a very realistic option, and it's not a treatment of last resort. However, the range of candidacy for children with epilepsy for surgery is much wider than you might see in the adult population. Mm-hmm. Certainly they may present in a variety of different ways. Even children with what appear to be quite focal lesions may have quite generalised features to their EEG or indeed their seizure type, and they may have a high rate of learning and behaviour difficulty. We know that early onset epilepsy and ongoing seizures is associated with poor neurodevelopmental outcome. And our premise is that the earlier we curtail seizures in their natural history of their condition, the more optimised chance they have of a better educational outcome, a better psychosocial outcome, a better neurodevelopmental outcome. And therefore, the earlier we assess these children, the better in the long term. But because of the range of different presentations, the range of pathologies we see, the likelihood that they may need perhaps wider resections that may see in the adult population, they need to be assessed in centres who specialise in children with epilepsy, with ongoing seizures, and assessed early, not waiting until they've failed numerous medications, but assessed early in the natural history of their condition.
Mm-hmm. And how would you address the concerns of a clinician who feels epilepsy surgery is a very dramatic or a big step in a very young patient, and perhaps we should try one more drug or something short of surgery?
Epilepsy surgery has moved a long way since newer developments in neurosurgery, namely the safety of neuroanesthetic, the safety of the procedures, the guided procedures that we now have intraoperatively. It's a much safer procedure, and of course it's an elective planned procedure. And in that circumstance, the morbidity is relatively low. You could argue there's a far greater morbidity from ongoing seizures, ongoing medications, and the effect on the learning, the risk of SUDEP with ongoing seizures, than there is from a planned elective focal resection. Mm-hmm. In a pre-surgical evaluation, we're not only looking where seizures are coming from, but also utilising all sorts now of non-invasive techniques to determine the function of the area of the brain to be removed. And in the vast majority of cases, there is very little, if any, function in that area. So we're not anticipating a further neurological deficit as a result of the surgery. And therefore, we're always weighing up the risk-benefit, but in far the majority of cases, particularly those selected carefully, the risk is far lesser than the benefits of surgery, and therefore it's a much safer way forward than actually even trialling in a further medication.
So where do you think the epilepsy surgery evaluation should fit in the course of treatment of a patient with epilepsy?
We always talk of children with refractory epilepsy being evaluated, and I think the new definition of refractory epilepsy, namely at least 2 drugs trialled over to a reasonable dose over a reasonable amount of time rather than a set amount of time, is the way we need to think about it. But children under the age of 2, all children under the age of 2, or young children, you could argue under the age of 5, who have a localized brain lesion at presentation of their epilepsy, should be referred into an epilepsy surgery program to be evaluated. It may be that the decision is made that it's not the right time to operate, but at least they've been evaluated in that decision made, rather than wait for several drugs and have the consequences of the epilepsy and then be evaluated in a surgery program. In older children, there may be an argument to waiting for at least 1, if not 2 drugs before the referral in. But actually in children with easily accessible, for example, glioneuronal tumours in the temporal lobe, you could argue that even in a presentation but under the age of 10, that actually it's much more likely that child will be weaned from medication and be seizure-free in the long term, with indeed removal of that lesion, although that still needs to be evaluated in an epilepsy surgery program.
And currently, what does the data tell us about the delay between how old children are when they present with seizures and the time that they actually have surgery?
If we look at the epilepsy surgery survey that we had performed in 2004, and this is it's 10 years ago, but what we did was evaluate within the Pediatric Epilepsy Surgery Task Force of the International League Against Epilepsy, we recorded all procedures that have been performed over a 12-month period from 20 centres. And again, we did that again subsequently to look at outcome, where we had data for an additional 26 centres. So we had in excess of 700 patients. And what that showed was that 60% of the children who came to surgery had presented under the age of 2 years with their first seizure. But there was a whole range of ages at surgery. So some had considerable delay, and only a third of those children had surgery within 2 years of presentation of their seizures. And we know that we should be able to identify them at that stage. So although accepting there'll be some children who you need to reassess and wait and watch, many, particularly with localized brain lesions, should be coming to surgery sooner rather than later, and there is still considerable delay. Some adult data suggests delay has come down from perhaps 20 years to 14 years over time, but that's still a considerable delay. And I think there's, we have to bear in mind that we should be operating on most children in childhood and not waiting for them to get into adult programs.
Is there data from that survey on the children who were operated at relatively short delay? Developmentally, did they do better compared to children who had a longer delay?
Certainly there are data from individual centres, particularly looking at children who'd been operated on under the age of 3 years. This is a study by Toby Logenkepper from the Cleveland Clinic that shows that the shorter the duration of epilepsy, particularly operated on under an age of a year of duration of epilepsy, they're more likely to show gains in development. Also, there's a large German study of school-age preschool children. Again, the shorter duration of epilepsy, the better the neurodevelopmental outcome. And again, the infantile spasm studies from UCLA show exactly the same thing from a surgical point of view. So there is several institutional sets of data that show the shorter the duration of epilepsy and the earlier the operation, the better the neurodevelopmental outcome. The survey we did only looked at seizure outcome, which meant, and getting cross-sectional neurodevelopmental data across multiple centres is quite a task. But certainly there's individual institution data that suggests that, yes.
Well, thank you very much, Dr. Cross.